and a large mainstay of that is opiate analgesics. I get referred, most of my patients get referred to me by other physicians. Sometimes they're on opiate analgesics, sometimes they're not. And a lot of times I'm either helping wean off opiate analgesics or helping make recommendations on how to best package the medication regimen together. So this is something that I work with daily. The one thing I do have to declare is I'm with the SPICO's Bureau with Release, which is a long-acting gabapentin medication. So I thought we'd start off by just taking a look at a typical opioid candidate. A 40-year-old gentleman with chronic low back pain. He's got inadequate pain relief with his treatment of the pathology itself, with anticonvulsants, with NSAIDs. His numerical rating score is a 9 out of 10. It affects his work life, it affects his family life. He's not working actually because of back pain. He feels a lack of intimacy with his spouse, whether it's because of pain, whether it's depression, whether it's the problem of back pain itself. This is affecting his mood. He's depressed. He doesn't feel like he was depressed before having back pain, but he feels like he has a reason to be depressed because of the back pain. And he has no history of substance abuse. So would this typically be somebody that we would feel comfortable writing opiates for? Why not?
Yeah, sure. Why not?
Okay.
I don't think so. You don't know the cause of his pain.
We don't know the cause of the pain.
It's totally subjective right now.
Okay.
Some objectivity.
And Dr. Wills, you were saying you feel comfortable prescribing opiates for him.
Opiates are appropriate medications for chronic low back pain.
And why not?
Without complicating factors, the likelihood of chronic low back pain being structural or functional is very low. And the first treatment is anti-inflammatories followed by physical therapy and rehabilitation.
Sure, and when I mentioned inadequate pain relief, I meant along the lines that he's doing those traditional treatments initially. But let's say if it wasn't back pain, let's say it was osteoarthritis. Let's say he was 6 years old with osteoarthritis. Was that somebody we'd feel comfortable writing opiates for? He may be a candidate. He may be, in some eyes, a suitable candidate. Traditionally, I think a large population of us would be writing opiates for him. You mentioned the point about the studies haven't shown that there's been any long-term benefit with opiate analgesics, and we'll talk about that with chronic low back pain. In fact, in long-term studies, there is no medication that's been effective for long-term for chronic low back pain except for the SNRIs. So we start him on an opiate, assuming that we start him on opiate analgesics, and he takes them as prescribed, and he doesn't miss any of his appointments, and he's reviewing the Louisiana Board Pharmacy Career Report. He's got a monogamous relationship with us. He reports a good response. His pain has decreased from a 9 out of 10 to a 6 out of 10. He returns to work, and he has better energy. That's a lot of times we'll all have anecdotal evidence like that ourselves. We'll have case studies like that, or we'll have our own patients have something similar to that experience. What's the evidence for this scenario? Valentine and Shin looked at the efficacy of opiates for chronic pain, not just chronic low back pain, I use that as an example, but chronic pain in general. And they were able to pull up some case series, and they looked at an 11 case series. There was a significant pain relief with chronic opiates, with opiate use for any type of chronic pain. And most of these studies also showed an improvement in function, but this improvement in function was only self-reported. There was no objective findings. The problem with this, and with many other studies that look at opiates and use it for chronic pain, is they're all less than 2 years. And most of them are going to be sponsored by drug companies, and they're actually closer to 16 weeks, 12 to 16 weeks. So I guarantee you have a problem with pain. You can get good pain relief for 12 weeks, for 16 weeks with opiate analgesics. But the question is, what becomes longer? How do we treat chronic pain after the 2-year period? And most of the studies, in this case, the evidence for using their use for opiates in chronic pain is in studies less than 2 years. Nobel and al. Looked at long-term opiate management for chronic non-cancer pain, and they had a 25-case series. And again, most of these cases reported significant reduction in pain, and they're inconclusive on function or quality of life. And their studies all looked at studies that were less than 1 year. So in summary of the observation data, less than 2 years, there's a decrease in pain, and it's equivocal on function and quality of life. Typically, I'll see somebody like him 2 years later. Now the cold weather, this cold front we just had, gives him aches and pains, and so he's been increasing his dose escalating himself. He's done that multiple times. He has a family member who's sick, so he decides that it's his responsibility to quit his job and apply for disability because he has pain and stop working. His pain is a 10 out of 10, even though he's been dose escalating, and it's not helping him either now with his pain or his function. And the observational data on this shows that large population studies, so not the small case reports, but large population studies, don't support good analgesia nor restoration of function with opiate analgesics. And especially the studies that were focused on return to work, whether workers' comp studies, opiate use delays delays return to work and impairs function. And then there's data on safety concerns about falls, fractures, and death, which we'll look at in a moment. There was a study out of the Brigham and Women's Archives in Internal Medicine, December 2010, that looked at Medicare claims data analysis of 12,000 Medicare patients. And they found that they had elevated risks compared to other pain medicines. These pain medicines being Tylenol or NSAIDs or Celebrex and Vioxx. And they found, now they couldn't make a good, it wasn't a control, they can't make one comparing the other, but it was enough to raise a concern that there was 87% increased risk of death during this study for the people who were on opiates. In this case, they were treating osteoarthritis of the knee. And 68% increase in safety events, talking about usually GI events, and a 4.5 increased risk of fracture. These are some of the things that we're learning more about, in addition to the things that we normally think of the risks and adverse events of opiates, whether it be constipation, decreased testosterone, depression. Immunosuppression is more in preclinical studies, but I like to use that as an example for my patients if I'm trying to get them off of opiates. Respiratory depression, substance abuse, diversion, and overdose. Another observational study by Tolin in Journal Pain in 2011 showed that since 1980, there's been a 3 times increase in prescription of opiates for non-cancer pain, even though opiates haven't been demonstrated to be any more effective for non-cancer pain during that time, nor have they been proven to be any safer. Erickson, again, Pain Journal, looked at 228 opiate patients versus over 1,500 non-opiate users, and found that the opiate users had poorer health, inactive during leisure time, were generally more likely to be unemployed, and had a decreased quality of life. Numerous studies looked at the relationship of opiates and function and return to work, and there's a decrease in function and return to work on people on opiates, and when you taper them off opiates, there's an increase in function. And then there comes into the idea that perhaps maybe we're just using short-acting analgesics, and we should be using long-acting analgesics. Perhaps those are safer. Does anyone use long-acting analgesics because they think it's safer?
Use less, supposedly.
You use less? Does anybody do that?
Less of a total dose.
Sometimes I use it anecdotally for certain patients. I think they're too wrapped around the schedule of have to take it every 4 hours, and their mindset is this. So I think I kind of liberate them a little bit, freeing them, and I make them take it once or twice a day. But really, there's no increase. There's no study showing there's any increase in function, or there's no study showing there's any decrease in tolerance, or actually any increase in pain and decrease in suffering. But theoretically, I like to use long-acting when I can, if there's somebody who's in a cycle of constantly wedded to the clock. But there's no study showing more safety with long-acting or a decreased tolerance with long-acting versus short-acting. You question that one? Looking at that one?
Aren't there studies in the about hospitalized patients getting continuous infusions of morphine, getting better pain relief, and using less total dose of medication than ones getting PRN?
Could be, and there's no better medicine than an opiate analgesic. So we're talking about post-operative pain medicine, or we're talking about palliative medicine, or we're talking about cancer pain. But we're talking about chronic pain medicine, then opiates don't prove to be that case. So if we're talking about in the hospital after surgery, absolutely. So,
Sickle cell crisis, a bunch.
Absolutely. That would be acute exacerbation of chronic pain. So what do I feel about opiates in general? So I'm a pain management doctor. I should be emphasizing on pain. The last thing I really look at when I'm treating people with pain for chronic pain is their pain. My assessment is what can or can't they do. What are 3 things when they come to me that they can't do, that they want to be able to do, but they're limited from doing because of pain. And that's what I start on. So if I have the option, I don't start them on opiates, period, if it's chronic pain. Coming into medicine, I feel compassion, I should be easing their suffering, but knowing down the line that they're putting themselves at risk for increased fragility fractures, we're putting them at risk for cardiac events or GI events, and in the long term, I'm not getting them any better reduction in pain, nor am I helping them with their quality of life or their function. I try not to get them started at all. A lot of us are persuaded, perhaps, by the changes in making us feel, by drug companies, perhaps, that opiates have a place and you just keep on increasing the medicine until they get that sweet spot of pain relief. And then if they don't have adequate pain relief, you just keep on going up. And as long as they're not having respiratory depression, you just keep on going up. And that we shouldn't be so concerned about addiction. And that there's all this needless suffering going on, and all we need to do is prescribe more opiates. At least that's the impression I get sometimes when I get talked to by at different conferences. I think the goal should stop being what is their pain level, but rather what can't they do. So my assessment is what can't they do, and then everything I work towards is getting to do those activities. And if opiates aren't getting them to do those activities, then it's not part of the plan. For instance, I come up with a game plan. The game plan is the function. Is that physical therapy? Is that injections? Maybe it's opiate analgesics. But if the opiate analgesics aren't getting them back to work, then my game plan is to quickly take them off. So when I start opiates, I have to have an exit plan. You have to meet certain criteria, that we have to meet these goals, and if we don't meet those goals, we have to quickly come off, because it's too easy to stay on these, and they can be on it indefinitely. Who here uses an opiate agreement when they write for opiates? What do you like about the agreement? What does it serve for you?
Holds the patient accountable. Patients, we have unfortunately, we don't know a lot of the patients when we first see them. Most of these patients we get are new from other physicians and whatnot, so trying to make them understand there are risks and benefits of it. And, unfortunately, even though we were taught in med school, you believe your patient no matter what. But unfortunately, a lot of patients that we see, myself and yourself especially, you can't believe everything.
Right. Right. And I think you raise a good point also. It's not a legal document where if you cross this line, I wash my hands of you. Because sometimes, we're the best ones to be able to be treating them. Really, I think, like you were talking about, Dr. McMinn, it's a conversational point. This is where you can introduce to them, there's no one who writes this but me. This is where you introduce to them that here's our 3 goals, and if you're not meeting this, then we're coming off of it. This is where we talk about, there's one pharmacy. So I find the agreement is good because we've opened up a conversation, not per se that if you took your sister's medicine that I'm washing my hands of you, because I recognize that it's not a pure. I'm not always getting the purest of the pure, and I'm trying to help everyone I can. I feel like I'm in a good position to do so. So it's really a conversational point. Does anyone not use when they prescribe opiates, does not use the Louisiana Board Pharmacy Query Report? Is everyone familiar what that is?
We mean not use it. We don't use it 100%.
Okay.
What is it?
So the Board of Pharmacy puts out a wonderful database of everyone who gets their opiates. It puts out which physician's prescribing it, and which doctor, which pharmacy they're going to, and the date. Now, it's not always great. Sometimes it's off by a month and a half. And it doesn't, a lot of times it's self-reporting, so the big pharmacies do it, but sometimes the mom and pops don't. But at least it gives you an idea. At least it gives you an idea that you see 6 physicians on there. It might not be, might not see the 7th, you might not see the last week, but telling you that 6 physicians tells you a lot of information.
Yeah, and just so you know, the external history that is in our computer system doesn't have any of that stuff. Because that's only the prescriptions like the lisinopril and all this other stuff, and all this other garbage they're buying with cash and other places. So if you look at external history, you're not going to see the full story, if you will, in this.
If they got it through their insurance at Walgreens, would it show up on that as well?
Yeah, it should show up in external history, but there's so many of the drug seekers
Right.
that don't show up on external history.
Right. Well, a lot of it doesn't show up on the pharmacy either, pharmacy report, because if they're going to a small pharmacy that they know doesn't report, it might not show up on there either. The other thing I do to help limit opiate escalation is I don't do refills on the telephone. I only do them in person for a couple of reasons. One is it's the conversation each visit. Why are we still on this dose? Why are we still on this particular regimen? I don't always do it, but I give them the expectation that we're always going to come down either on dose or frequency. And if we don't, then they love you for it, but that's the expectation. And I usually let them choose. My decision is we're coming down. Your decision is we're coming down on the dose or the frequency or the long-acting or the short-acting, but we're always coming down. The other thing is if it's like, if I prescribe Cymbalta and every 6 months it's just routinely prescribed, it's just expected that I do that. So if I do it on the telephone, it's just, you always do it. What do you mean 90? I get 90. What are you doing? But when you come in for an office visit, it's not expected. It's assessment every single time. So, and the other thing is a lot of times I have the experience that somehow the telephone calls for opiates only come on the weekends and only come after clinic hours when they know that I'm not really as diligent, or maybe it comes at 4:30 when I'm not as diligent. So I don't bother. Just like I don't bother with pharmacy fax requests either. Because does anyone get bombarded with fax requests from things you just filled a week ago? So I feel like it just goes on a trigger that they're just trying to capture that, and so it's incredibly burdensome and not even prescribing those medicines half the time. So I refuse those as well. Somebody has to call in for that, and then opiates have to be handled during the office visit itself. When it's time to stop opiates, opiate withdrawal is something that we can temper, although it's not life-threatening. I've had many patients who have not been able to come and see me and have been off the medication for a week or two. And we may restart it, but they went through opiate withdrawal, and it was very unpleasant, but it's not life-threatening. Sometimes there is increased sympathetic. There might be occasions when you wouldn't want that, and that could be life-threatening. But otherwise, other than certain comorbidities, that is not. I use NSAIDs for the muscle aches. I use Cymbalta a lot for chronic pain. Cymbalta is actually the only medication that I know of, and this was about a year and a half ago, and I didn't actually look at it in the past year and a half, but it's the only medication I know of that has longitudinal studies that looks beyond 2 years and finds a medication that's effective for reducing pain and improving quality of life and restoring function. So I use it in general for chronic pain. It works by the inhibitory pathway, elevating natural levels of serotonin and norepinephrine, strengthening your inhibitory pathway. But particularly in weaning of opiates, I use it not only to replace the opiates that we're weaning, not only to help with chronic pain, but also to reduce anxiety. And then clonidine is best for some of the symptom effects of sweating, tachycardia, hypertension, and nausea. Some alternatives that I use to opiates. My baseline of treatments for medications when I'm treating for chronic pain are going to be my anticonvulsants and antidepressants. SSRIs have not been shown to be effective in reducing pain. SNRIs like duloxetine, which is Cymbalta, is, and of the ones that you see there, Cymbalta is the most studied, having indications for chronic low back pain, fibromyalgia, diabetic peripheral neuropathic pain, osteoarthritis of the knee, in addition to depression, anxiety, which is often a comorbidity. So if I had one medication, it's the one I often use the most. I'm looking for patients who may have liver problems. I'm not going to prescribe it for that, but it hasn't been demonstrated to cause liver problems in and of itself. Tylenol, often for elderly people, is often sufficient, NSAIDs and topicals. Who here uses a fair amount of topicals? Or what's your experience now with these topical compound creams?
I think you have to be selective in who you use it on.
Yeah.
I don't think there's some people who just give that to everybody who comes into the pain world. I think if you selective, I've got really good benefits with it.
Yeah.
What's an example of topical?
There's almost, if you're in an outside clinic right now, there's not a rep that's not selling a topical compound cream. Every rep for every product is picking this up at the same time because there's this ungodly amount of reimbursement going on right now that will change quickly.
What is it?
Right, so it is a combination of oftentimes a local anesthetic, a neuropathic agent, a muscle relaxant, sometimes ketamine or something similar to ketamine, and it's
Really?
It's done transdermally. Potentially there's some decreased incidence of side effects, potential for it, because the less GI uptake of the NSAIDs or topical NSAIDs may work applied more closely to where it's needed. There's, I think, 30% increase, 30% uptake in the GI system as compared to orally. Whether that correlates with a 70% reduction in GI risk is not known, but theoretically there could be a decreased risk. I find they're completely innocuous. Sometimes they're helpful, sometimes they're, more often they're not, but sometimes they're helpful. I find it's, oftentimes I'm trying to add something as I'm taking away opiates, so even if they don't get great benefit, it gives me time to start weaning down some more
You
opiates.
sort of like a Voltaren gel or something?
Now, Voltaren gel is I wouldn't call it a compound cream, but it is a topical. It's just a clofenac. So
Is that a local effect or is that a systemic effect?
it would be, it's local, but 30% of it gets taken up systemically.
The compound medications are specialty pharmacies that do it. It's something you prescribe through one of their pads, and you send to a specialty pharmacy, and they mail it down to the patients.
Right.
So the fentanyl patches in this category you talked about, is that another category?
Well, fentanyl patch could be put in the topical as well, as far as transdermal, and that's taken up completely systemically. So it would be like a lidoderm patch, which works could work locally, but fentanyl patch would work completely systemically. I try to avoid fentanyl patches only because I'm trying to wean down opiates and work on function. And now, if I had somebody who was completely, that I wasn't working on function and I wasn't trying to challenge them, then I think it would be it's a fantastic drug. The reason why I try not to use it is the jumps are so big. To go from 25 to 12 micrograms is very difficult to titrate. So I prefer to use orals if I can do oral, so I can make a smaller wean, more tolerable wean. Of course, diet and exercise, physical therapy, cognitive behavioral therapy, complementary medicine techniques, nerve blocks, and device treatments are all things we can do and alternatives to opiates as well. Device treatments are things like spinal cord stimulators, which are oftentimes in conjunction with pain management physicians, orthospine or neurospine, for people who have had back surgery and still have symptoms of lumbar radiculopathy, or perhaps have spinal stenosis and aren't candidates for surgery. You can thread in a thin little epidural catheter that had, instead of being hollow and putting medicine through it, has electrodes on it. Those electrodes sit near the nerve roots and help block the signal of pain, worked by the gate control theory of pain. It's very expensive, and it's thought to pay for itself in about 18 months, 24 months, which is about the amount of time that insurance companies think that you're going to stay with their insurance company. So it's often can be difficult to get approved, but can be a godsend for people who can't keep on getting epidural injections or aren't candidates to get repeat surgeries, or for people who have had that first back surgery, which can be very beneficial, but oftentimes a second or a third has been shown to not be dramatically help reduce pain. There's something called REMS, which is Risk Evaluation and Mitigation Strategy. It's not something that I actually participate in, but it is something as I was preparing this lecture, I thought it'd be good to have that in balance, and I thought it was interesting. I'm going to look a little bit more into it myself. You can train yourself on the use of long-acting opiates. I think these are the lists of some of the more typical extended release or long-acting opiates that are part of this program. They look at 3 or 4 things. As part of the risk evaluation and mitigation strategy, you're asked to train yourself on the proper use of these medications, to counsel patients about the risks of these medications and to document these conversations, and to emphasize training not only of the patients but the caregivers involved. And there's also other tools that are available to whether it be opiate agreements or risk assessments that are all available at this site here. And this is an example of an ongoing conversational piece that you would be expected to participate with your patients about what to do and not to do with your opiate analgesics. There's a newer type of opiate analgesics as well that, whether through the pharmaceutical companies or through the FDA, are trying to deter abuse. Suboxone, Embeda, Opana. The newer formulations of Opana, OxyContin, and Exalgo. Suboxone is buprenorphine with naloxone, and Beta is morphine with naltrexone. So what they're looking at is to prevent the medication from being crushed and then placed intravenously, you would get the antagonistic effect of the naloxone or the naltrexone. Opana and OxyContin. Opana is oxymorphone and OxyContin is oxycodone. Both of them have newer formulations that are tamper resistant. I always thought, and Exalgo is dilaudid, I always thought that these medications, to me, weren't that special. So they couldn't be tamper resistant. I mean, so they're tamper resistant, so they can't be crushed, and they can't be snorted, and they can't be put IV. To me, 99.99% of medications are abused because you take too much. Because you get it from somebody else, because you go doctor shopping, because somebody's prescribing you too much. That's where the real problem lies. Not in somebody using it intravenously when they shouldn't do, which is a fraction which is completely off my radar. However, when Opana came out with the new drug-resistant formulation, I started looking up online. And if you ever looked up your own name online, trying to find your own address as a clinic, you're like your 15th website. You got the vitals, you got this, rating of you, that rating. And similarly, you look up Opana or any of these medications, you're not going to find Opana. You're going to find all the drug forms about people talking about how to take this drug and how to abuse the drug. And when Opana first came out, there was literally, it took me 3 pages to get to the actual medication Opana because everyone was complaining about how difficult it was to crush and use intravenously. So I didn't know it was a problem until I did a Google search. I'm sure they've gotten around it, and somebody mentioned to me, a pharmacologist mentioned how easy it is to actually get around it, but at least it deters some people. The point being, though, to me, this is not where the abuse comes from. The abuse comes from you prescribe 2 and you take 6, when you escalate yourself or you're getting it from other sources. So I find that the goals, the success I find with opioid analgesics is creating goals. These goals to me, have nothing to do with pain itself. And again, I'm distinguishing that, like we talked about, from acute pain or post-surgical pain. Clearly, we want them to leave the hospital pain-free, or as close to being pain-free, and we want them to participate in physical therapy in the hospital. But that's different than in chronic pain. In chronic pain, I'm setting goals of going back to work, of socializing, of exercising. And opiates often have demonstrated not to increase function. When I do prescribe opiates, it's for the reason that they tell me that physical therapy is very painful. Great. For a finite period of time, of that 6 to 9 weeks, I'm going to prescribe it twice a week. Once, 30 minutes before you do physical therapy, and then however much time afterwards. So they continue with it, so you get real benefit from physical therapy and you're able to participate that way. Not because you're in pain and I therefore need to prescribe something 4 times a day for the rest of your life. If I do start opiates, I have an exit plan, and we talk about the exit plan. These are the goals you're going to meet. If you don't meet the goals, just like if I started you on an antihypertensive and you're not coming down on your blood pressure, we're going to switch to something else. And there are alternatives that we talked about: injections, physical therapy, neuromodulation, different types of medicines. That's it. Yes.
One question. So we had a previous lecturer talk about addiction medicine and using genetic testing to determine how he should treat the patient. Do you use that at all in pain management?
I'm just starting to do it more as an experiment than anything else. I think it's on a frontier. You have some people who are fast metabolizers of the cytochrome P450 system. Certain medications are metabolized. Many medications are metabolized by the cytochrome P450 system. Therefore, you may get more analgesia or less analgesia from certain types of opiates. So somebody who comes in and says that they take X amount of this whopping dose of opiate, before I try increasing more, I might do a genetic testing to see if they're a rapid metabolizer, or slow metabolizer, excuse me. So that's where I've started to play with that a little bit. Yes?
Cognitive behavioral therapy has a lot of supportive literature, but I know it's not well covered by insurance plans. Do you find that your patients are open to it, or do you find a lot of resistance?
I think it's never the thing that I talk about first, right? First, I'm talking about how we're going to come off the opiates, and we're going to do the physical therapy. Those are usually the 2 biggest things. Then the second conversation is talking about how Cymbalta, I'm not using Cymbalta for depression, even though it's an antidepressant. It's much like aspirin. Aspirin is used to thin your blood and treat your fever and treat your pain. So I'm not giving you a fever medicine when you go to the ER because you have chest pain. It's used completely different. So that's the second conversation. Maybe the third or fourth conversation is about cognitive behavioral therapy. So I don't start away. I know I'm not saying it because you're crazy, but the first time I meet you, I'm not going to introduce that part. But yes, I try to do it as much as I can. not always well received by patients and very infrequently covered.